So along with two other speakers, I'm going to be talking about structural sexism and how this affects cancer patients, and also how it affects physicians and other oncology workforce members. The idea for the talk this year was initially, to think about gender equity. And that's a session that ASCO has put emphasis on before and has had some other fantastic sessions, including a book chapter last year that was co-authored by Dr. Velasquez Manana, who's also here at the UCSF Cancer Center. The focus in the past has been thinking about individual acts of sexism. So that's thinking about microaggressions and bias. So for this year, we wanted to put a different spin on it and talk about the topic in an equally important but different light. And so what we're thinking about is the structures, meaning institutional policies and rules and organizational practices that allow for sexism to continue. And then we also thought about what is the downstream effects of structural sexism. And we wanted to think about that also in a creative way and not just focus on the workforce, where that's something I thought a lot about before, about how this affects women and gender minority physicians, but also to think about how this affects patients and the quality of clinical care. We not only think about the forces that create this and what the effects are on patients and providers, but also how this could be dismantled. And the big picture outcome there is that this could actually lead to improved quality of clinical care in a number of different ways. So I'll give one example, that on the patient care side, we realized that women and underrepresented minorities are still under-enrolled to clinical trials. And some of them, there's a lot of factors that have to do with that. Some has to do with inadequate reporting and of enrollment by gender and by race and ethnicity. Some of it has to do with decreased outreach to those populations. So that's just one example about how there are structures in place that decrease the quality of our trial data and then downstream affect the quality of clinical care. Another example is in resource allocation. And so that's thinking about how do we make sure that resources in terms of research funding and other clinical resources are distributed equitably. And an example of this is we looked at gynecological cancers and how the majority of these are underfunded in terms of their funding in research dollars to their lethality score. So how many patients are affected by these and how many years of life lost. And there's been data that has been previously researched on this topic that we presented and summarized to show that cancers that primarily affect women are actually underfunded. So we advocate for more equitable structures and institutional policies that would allow patients and physicians to benefit. On the workforce side, we also looked at things like pay equity and the representation of women and underrepresented minorities in the higher levels of academic oncology leadership. And we really advocate here for a more diverse workforce that can serve a diverse patient population.